Good evening, dear colleagues. First, thank you to Blue Sky Bio to host me for this webinar. You know that now it's midnight in Nice, France, but it's my pleasure to share with you my scientific and clinical experience. I would like to talk about A-PRF and i-PRF in this webinar. Growth factors are routinely used in oral surgery. However, if we want to improve our clinical results, we must use the adequate product, and we must use the adequate protocol. Also, integration and wound healing, we need cells, we need hormones, we need protein, and we need growth factors if we want to achieve this wound healing. However, the main objective of this product is to achieve a new angiogenesis. We use usually a platelet concentrate technique. Only by this centrifuge we will increase the platelet count. It was the first concept of this kind of regenerative product. We have now three kinds of protocols: the PRP, the PRGF, and the PRF. The difference between these products is the use of anticoagulant or not. Why to avoid the anticoagulants? If we go back to the hemostasis pathway, when we have injury, we will have a blood clot and the fibrin clot. This clot will release growth factors from platelets and white cells. And then we can obtain a new vessel growth for cell simulation, and then we will have wound healing. We need the platelet clotting because these platelets, they can secrete their growth factors only after clotting. But if we want to get the clot, we need to avoid the anticoagulant. This is the concept of platelet-rich fibrin that I described in the beginning of 2000. The principles are first to get a physiological clotting because we need a biological product. And at the end of the spin, as we avoid anticoagulant, we will have a fibrin clot who contains the growth factors. These factors are protein who stimulate cellular differentiation, growth, and proliferation. These factors, they communicate with cells through a specific receptor on the cell surface, and these factors, they play a predominant role in wound healing. We have several factors, around 150, and everyone has a specific action. For example, if we want to understand why we have an osteonecrosis of the jaw when we use bisphosphonates. We know that the bisphosphonates, they modify the bone metabolism. But the most important factor is that when we use bisphosphonates, we reduce dramatically the secretion of one specific factor, who is the KGF, keratinized growth factor. This factor is responsible of the healing of the gingiva. And then when we do extraction in this kind of patient, we will have a very, very slow healing of the gingiva. And then without healing of the extraction site, we will have an infection of the bone and then osteonecrosis. What kind of protocol we have to use? We know that we have PRP, PRGF, and PRF. If we draw blood from the same donor and we take 3 tubes and we apply on each one a different protocol, PRP, PRGF, and PRF. If we want only to be focused on the platelets, we have the same amount of platelets in the 3 tubes. It seems that it's not sufficient to talk about only platelets. The difference is coming from the handling first. In the PRF, we have no handling. Why? Because we put the blood in the tube and we leave to coagulate itself physiologically. We don't need to handle any product. And then if we have no handling, the reproducibility will be better. And clotting is physiologic. We don't need to add any kind of product to get a clot. Because the clotting mode influences the fibrin structure. The structure of the fibrin affects its biological function. Yes, we need fibrin, but we need a physiological fibrin. The wound healing outcome depends on the fibrin structure, and this is why we need to obtain a natural fibrin clot. We can compare the product with the amount of leukocytes inside. In PRP, we have between 0 to 50%. In PRGF, we have no white cells, and in the PRF, we have 50% at least. However, the most important property of a platelet concentrate is how do we release the factors into the side. In the PRP, the release is immediate. We don't know about the PRGF. And for the PRF, we have a slow release for around 7 days. Why this property is so important for all the factors? Because the fibrin is a recipient of factors, and this fibrin will release slowly and continuously the factors. But we know today from the science how these factors have to be efficient. We need a stable growth factor gradient. We need a long-term release. We need a continuous release. We need a very slow release of factors if we want to achieve a good vascularization. We can compare this concept to the biologic concept as, for example, when we want to treat a very severe infection, what we do intravenous perfusion of antibiotics, but we inject this amount of antibiotic in the full day. It seems that in 1 minute or in few minutes, we infuse only a very slow amount of antibiotics. The efficiency of the perfusion is coming from a very slow injection with a constant and stable concentration of the antibiotics. We can also compare to a very simple concept. When we want to hydrate the green grass, what we do drop-by-drop irrigation. The essential is to put water at a low concentration and low dose, but continuously. The drop-by-drop irrigation is the best. Let's go to the concept of the PRF. As we have no anticoagulant, we need to draw very fast the blood. Because if we draw the blood drop by drop, the blood will coagulate during the drawing, and then we cannot separate the fibrin from the red cells. The drawing has to be fast, but we have to start immediately the speed. Never forget that we have no anticoagulant. And then if we have a drawing drop by drop, we will have a poor clot. For the protocol, we have to use a balanced position, 2 or 3 or 4 or 6, 8, 9, 10, 12. The balance has to be all the time. And then at the end of the spin, we will have a natural concentrated human blood without red blood cells. The PRF is the fibrin clot in the middle. We will take this clot, we can put on a gauze, but today we use the PRF box. Why to use the PRF box? Because we have to press slowly and continuously the clots to get membranes of fibrin, and these membranes we will use all the time, the PRF in membranes. Because if we want to cut in small pieces, it's not easy to cut a clot, but it's so easy to cut the membrane. We will mix these pieces of fibrin with the biomaterial. We can suture the fibrin easier. And then the preparation with the PRF box is very simple. We take the clot, we scrape. We don't need to cut. We scrape the red cells, and then we have the full clot. We take the clot, and then we scrape the red cells. It's a very simple protocol, and then we use the tray and the lid of the box. The lid of the box will press the membrane to get a fibrin membrane with all the time the same thickness, and the handling will be very easy. This is after 1 or 2 minutes, and then it's very easy to handle the membrane. We can fold twice when we want to put it in the sinus under the Schneiderian membrane, and we can use the pad to put the membrane and to cover the biomaterials. We have in the bottom, we have a fluid. This fluid is coming from the clots, but the essential of this fluid is that it contains a lot of adhesive proteins as fibronectin and vitronectin. We can prepare now plugs and punch. How to prepare a punch? With a bistoury, with a blade. We put the membrane on a gauze, and then we do incision, like this. We have to put first the membrane on a gauze, and then we can do punch. 2, 3, 4, it doesn't matter. We decide how many punch we want to do in one membrane. We put the membrane on a gauze, and then with the bistoury we do a punch. And then we go back to the box, because the storage has to be done every time in the box. We can store the membrane in the box a few hours. We check the punch, and then we can apply on the site. We did the full arch immediate implantation, and then we want to cover the whole site with fibrin. It's easy to manage the membrane punched, because we know today that when we do a flap, we will have a bone resorption. And to prevent the bone resorption, we will use the PRF, and with this application, we will increase the production of phosphatase alkaline, and then the phosphatase alkaline will reduce and will stop the bone resorption when we do a flap. And we can protect the connection of the implant with the abutment of the cover screw. And then we use the pad as a palette for cake to manage exactly the membrane on the site. You see how it's easy to manage the membrane with the pad. We can make plugs for socket preservation. We have in the box cylinders, and then we will fill the cylinder with the clots, and we will press with the metallic piston and then we will push the clots. But in this position, it's not enough down, and in this position, it's too deep. The right position is when the metal piston is at the level of the white cylinder. And then we can use these plugs in the socket when we do extraction. This is a video we did with my friend Patrick Palacci. We take the clot, we put it in the white cylinder first. And then we can crush them. We stop at the level of the white cylinder. We have now 3 plugs, and we will go to the side to fill the socket. The first plug is easy to manage, no problem, but we need to put as much as we can. This is one of the best concepts of the PRF, as much as we can. But if we want to press, we need to use a gauze, not with the metal instrument. This is the third plug. We try to put it. It's not easy, but we will do with a gauze. Press with a gauze every time, as much as you can. And then, you see, we put in the socket 3 plugs. It seems that we put in the socket 30 cc of blood. How we started? We started in the beginning of this century. I used the PRF in my own pain clinic, and I treated this old woman who has a very severe infection in the leg. She was referred because she had pain, and I started to use the PRF not to treat the pain, but only to induce new vascularization on the site. And look what happens after 10 days. We have a lot of vessels on the surface. And if we have the vessels, we will have the healing. This is the concept. We need only to promote new vessels growth. When you have this case, it's a foot amputation of the fingers after diabetic problems. And after the surgery, the patient has had dehiscence and infection. We treated with PRF. The objective was only to get vascularization. After 1 week, we got it. And if we have vascularization of the surface, we will have the healing, obligatory. Today we have a very huge, how to say, very large publication, and we have now a good evidence on the PRF in not only in the dental field, but also in orthopedics and aesthetics. However, do that these platelet concentrates are constantly active? I can tell you no, because in medicine, you can have the best product that you can, but if you apply a wrong protocol, you will have a failure. We need to apply specific protocol to achieve the healing for the blood centrifugation procedure, but also we need to apply a specific protocol for each clinical indication. For example, this is a PRF after a good protocol. If we do not achieve good protocol during the blood drawing, during the spin, we will have a very poor clot. But also, we have to apply a specific protocol. For example, in the sinus, we have to put the PRF under the Schneiderian membrane. It's obligatory to put the PRF under the Schneiderian because we will induce new vascularization coming from the mucosa, because Schneiderian is a mucosa. We have to respect all the time the protocol. This is how we put the fibrin membrane with the pad in the sinus. The PRF has to be folded twice. And then we have 4 layers under the Schneiderian. In the clinic, when we do a flap, we know that we will have bone resorption. It seems that when we do a flap, we have to cover completely the site to protect the bone and to avoid the bone resorption after a flap. The concept of the PRF is that the fibrin is a matrix, is a tissue matrix, and the PRF has to be used as a matrix and also as a recipient of growth factors. The matrix, the concept of the matrix is in that when we have a lack of tissue, we can put the fibrin here. And this fibrin, as it's the best matrix that we have in our body, we will get a new tissue. And this tissue will be very stable after 2 years. The concept of the PRF is only to put a fibrin matrix in the site. When we do extraction, we can fill with biomarker like allograft. We will cover the graft with the fibrin, and as we know that we need to avoid to get a primary closure. Why? Because this position of the gingiva is physiology, and then if we want to respect the biology, we need to leave the gingiva at the physiological place. And then with the fibrin, as it's a good tissue matrix, we will get a new gingiva in place of this fibrin. The concept of the matrix is always the same. In this case, we did extraction and we wanted to treat an implant failure, and the dentist wanted to use a Gore-Tex membrane, to do a GBR with Gore-Tex membrane. But the problem with the Gore-Tex is that sometimes we have some necrosis. It seems that we have to remove this Gore-Tex membrane, but we know that we cannot achieve a primary closure. But it doesn't matter. The fibrin will do the job. We can cover a few layers of fibrin, and then we know that we can leave the site exposed. Why the fibrin is the good product for this situation? Because fibrin is a natural product. You can leave the fibrin exposed. You cannot leave a collagen membrane or a biomaterial because they are not a physiological product. And then after 10 days, we see that the vessels invaded the fibrin, and then we are getting a new tissue, a new gingiva. After 8 weeks, we have a new gingiva in place of the fibrin. And if we want to check first what quality of tissue we have, we can harvest a piece of gingiva to do an histology study. But first, we wanted to know if we had a safe graft. Yes, the graft was safe, and the dentist put 4 implants. But if we analyze on the right the new gingiva from the fibrin and we compare to the other side of the gingiva, we see that it's a normal fibrin, a normal gingiva, sorry. It's a normal gingiva, but it's a young gingiva. We can use the PRF also for root coverage. PRF as a connective tissue graft. When we have recession, we can use the fibrin as it's a very good tissue matrix, but the protocol has to be with the fibrin exposed because we want to get more tissue with this concept of matrix. And then look how the flap is moving up at the place of the fibrin. and then you will obtain a very nice amount of keratinized tissue. When we have a very unfavorable biotype, we can use the fibrin, the PRF, as a connective tissue graft. We can do a flap using tetracycline, few layers, every time as much as we can, and then the protocol is to leave outside the PRF. The PRF is in front of the teeth, and then if we go 1 day after, look where are the vessels at the place of the fibrin. But if we are able to achieve a very fast vascularization, we will get a very nice new tissue, a keratinized new tissue after a few months. This is the concept of a tissue matrix. When we leave the fibrin exposed, it doesn't matter because it's natural product, we will get a new tissue. This is the concept of a matrix. We have now several publications comparing the PRF and the connective tissue graft, and they found the same results. We can use the fibrin to cover the palatal site when we do a harvest in the palate. We know that it's painful and sometimes the healing is not fast. We will suture the fibrin to the site and we will get very fast healing of the site without pain. How to use the PRF in socket preservation? As I told you, we have to put as much as we can. But we have also to respect this biologic concept is to leave the gingiva at the right and at the biological place. We need to leave the gingiva at this place. And then what we do, we suture only to maintain the fibrin inside. And then we will have a very nice healing. Every time when we do extraction, we try to use biomaterials, we try to use membranes, collagen membranes, but from my point of view, the best healing will be with a fibrin clot. We can put the fibrin in all the extraction site, and then we can cover also. For this case, we did a flap, and look after 3 months how much bone we have. But the most important is first how much bone we have, but also what is the quality. The quality of this bone is a natural bone. It's a full natural bone. And then we can put the implant in a vital bone. The essential is to get a vital bone into the socket, and then the implant will be placed in this kind of bone. We can use the PRF in sinus lift. As I told you, we can put the fibrin under the Schneiderian membrane, folded twice, but we can also cover the bony window with the PRF. We know that today we can use the PRF at the place of a collagen membrane. We have publication about this kind of protocol, and we did not find any difference by the use of PRF or collagen membrane when we use it as a closure of the sinus window. We can also use the PRF to repair some tears in the Schneiderian membrane. We use fibrin, and then the fibrin sticks immediately to the Schneiderian. When we have perforation, we will apply PRF, and then we will get immediately the breathing. And we can continue the procedure and to make the bone filling of the sinus. When we have perforation, immediately when we place the fibrin, we get a breathing of the sinus membrane, and then we can fill the sinus with the biomaterials. However, we can use also the fibrin as a biomaterial. We have several papers today, and we can use in the crustal technique and in the lateral technique. But in the lateral technique, we have to put first the implants, and then we can fill with the fibrin the sinus. After 6 months, we will have a full healing of the bone into the sinus, because the fibrin is the best biomaterial that we can use in the sinus. We have today a lot of publication about this concept of using a PRF as sole biomaterial in the sinus. We started 10 years ago using the same concept, fibrin under the Schneiderian, and look, after 9 years, the stability of the bone. This bone is very stable because it's a native bone. When we have perforation, we use PRF, and then we can place the implant and fill the sinus with the PRF. And after 6 years, we have a very stable bone because it's a vital bone. Today we have several publications, and the last was in the Journal of Craniomaxillofacial Surgery about the use of PRF as sole grafting biomaterial. However, we are in medicine, we are in surgery, and the most important is not the product. I can tell you that you can use the best product, but if your protocol is wrong, you will not have a good result. The essential in the medicine is which indication. Yes, the indication depends on the palatal buccal distance. When we have a narrow sinus, it seems that the gap is small, and I can guarantee you 100% success. When the size is medium, we have to check. When the size is wide, we have to avoid this concept and this protocol. When the gap is small, we can fill only with fibrin. The results are fantastic. When the sinus is narrow, we will have a bone because it's easy to make bone in a small gap. When we have a wide sinus, please forget this technique because you cannot obtain a good result. And then you have to use biomaterials in this indication. We can use also PRF immediate loading. When we do extraction and implant placement with grafting biomaterial, the question is how to suture the site. We can use only fibrin because we know that this PRF is a very good tissue matrix, and then we place the provisional crown. After 1 week, we have a very fast healing, but if we remove the crown, we see that we have a new gingiva. This is the concept of a tissue matrix. And after 1 month and the final result of the aesthetics, with a very simple protocol. However, today we can talk about the scientific evidence. What is the scientific evidence? We need vessels because the bone formation depends on the vessel volumes. And then if we summarize the concept, we put biomaterials. First we need cells because they will produce extracellular matrix. And this extracellular matrix is obligatory, and then the vessels, they can start to grow. And if we have vessels, we will have bone. The bone depends on the vessel volume. What is the concept of the PRF in bone growth? The PRF is active because the plasma-derived protein, such as fibrin and thrombospondin, act as provisional extracellular matrix. And you understand the concept. You put a matrix, a provisional matrix, extracellular matrix, and then we will have a very fast vascularization, and we will have faster the bone formation. This is why my advice is always to use the PRF mixed with biomaterials. We need to cut first the fibrin in small pieces. And then we will add the granules. We mix the granules with the fibrin. It's dry, but it doesn't matter. We will add the exudate from the box. in place of the saline solution. It's better to use the exudate. And then we mix the granules with the fibrin pieces and the exudate. And what we will have, a sticky ball. This is a sticky bone when we use this protocol, mixing the granules with the fibrin and the exudate. The PRF is active on the hard tissue because PRF induces vascularization. And if we induce vascularization, we will have a bone growth. The PRF is active on the bone growth because the fibronectin, who is in a high concentration in the PRF exudate, the fibronectin acts as provisional extracellular matrix. We need this liquid to hydrate the granules because we know today that the plasma protein are very active on the collagen gene expression stimulation. A very interesting paper on comparison of a PRF clot and a PRF membrane. Do we have to use a clot? Never. We have to use a PRF membrane because with the membrane we will have more vascularization, around 100% more. Now I can move to the advanced platelet-rich fibrin. Why we have to move to this concept? Because the science is running, and we have now a lot of new information about the white cells. When we increase the white cells, we increase the results. Monocytes are super cells for bone regeneration. The monocytes are very important in the osteogenic signals to progenitor cells. The monocytes, they induce promotion of osteoblasts from mesenchymal stem cells, and they contain BMP2 receptors. And then, if they contain receptors, we have chance to have production of BMP2 from their cells. But if we want to have monocyte active, we need also to have granulocytes, because the granulocytes, they induce transformation of monocytes into macrophages. And it was urgent to add the monocyte and the granulocyte in the PRF. We designed a new tube, and I changed the protocol. And then we can see that we have more VGF, 50% more, because we have more white cells. We have more thrombospondin because we have more white cells. But we can produce BMP2 from the clot with a long-term release. We can produce BMP2 for free. We don't need to buy them. We have sufficient amount of BMP2 from the advanced PRF. But we have also a lot of BMP2 in the exudate. This is why we have to mix with this liquid with the granules, and maybe we can coat the implant surface with this exudate. And then we have from the science the answer about the monocytes and the macrophages. They produce BMP2 for sure. We have also a very nice synergy of monocyte and fibrin. The fibrinogen enhances production of bone and angiogenic factors by the monocytes. However, we wanted only to increase the vascularization. If we compare in vivo vascularization with PRF and with A-PRF, we have 2.5 times more vessels. This is what we wanted, only to increase the vascularization. Why we increase the vascularization? Because we have more white cells. I believe that the concept of PRGF without white cells is completely outdated today. It's not logic to avoid the white cells when we want to create inflammation, and inflammation will create the new vessels. When we move to the clinic with the new A-PRF, we do extraction and we leave the site open Why? Because this concept is biology. And look how the gingiva is growing naturally and physiologically. We don't need to achieve a primary closure. And then look at the level of the bone and the quality. We have a full reconstruction of the ridge. When we do this concept with A-PRF, we see that the gingiva is moving to get a primary closure. We don't need to achieve it at the beginning. Every time when you use this concept, we will close the site naturally and physiologically at 1 week. When we do this protocol, we don't need to use any kind of biomaterial in the socket, because with the fibrin, we will get in only 3 months sufficient bone to put an implant without any biomaterial. But also we can use this concept when we have a buccal bone miss. We fill with PRF, with advanced PRF, and we leave the site open and look at the amount of bone we can obtain after only 3 months. The same concept, missed buccal bone, advanced PRF, good preservation of the bone level, and good volume of the bone without any biomaterial. Because we respect the biology, we need to leave the site open. We can apply this protocol for soft tissue, and then with the advanced PRF, we have much better result when we use A-PRF as a connective tissue graft. Alexandre Alam from Los Angeles is doing a very nice job in this protocol, and look how we can increase the keratinized tissue. In the tunnel technique is the same. We do the technique, and we don't need to put any connective tissue graft or any membrane as a collagen membrane or any kind of membrane. We can use only A-PRF. This is the healing, and this is the outcome. We can use PRF, and we will have a very nice amount of keratinized tissue. Very simple, without any pain, and very fast. But the concept developed by Alexandre Alam in Los Angeles was to treat the full arch with this concept, only with PRF, and you know the Vista technique, very simple. We fill with the advanced PRF. In this case, he used the 8th membrane, and look at the final result. We don't need to put any other product. What is the future today for the PRP? Yes, sometimes we need to make injection. We have several products, and all the products are different because they are using different protocol and different enrichments. The question is, do we need only platelets? For sure not. We have to move to blood concentrate, because the platelets contain two growth factors, but we need white cells, because the white cells, they organize the vascularization and the osteogenesis. And the concept of a blood concentrate is the use of the plasma, the platelets, and the white cells. We don't need red cells. We need only the whole blood without red cells. And this is why I wanted to find a new blood concentrate as the i-PRF. i-PRF as injectable. The concept of a new product who is with no additive, no anticoagulant, and automatic. And for sure, cheaper than the PRP. We need the white cells, and when we compare the i-PRF about the amount of white cells to the PRP and to the PRGF and the autologous fibrin glue, what we see And what was our objective is to get a lot, and the majority of the white cells. We have 20 times more white cells than the PRP and more than 100 times more than the PRGF. We wanted the monocytes. We wanted the neutrophil. We wanted all the lymphocytes. But look, the platelet, we have the same amount of the platelets. And this concept of i-PRF will definitely change the use of the platelet concentrate, as we are now in a blood concentrate. This is the i-PRF compared to the PRP. We don't need a lot of liquid, but we need a liquid who is able to provide us a lot of white cells, because they are doing the vascularization. What we want to do with the i-PRF, we want to inject it. First, we want to sometimes modify the biotype. We have a very thin biotype, and if we inject this product as it clots after the injection, we will maybe modify the tissue. Look after 2 days only after the injection, how we increase the vascularization of the tissue. And we will present this study the next month in Paris during the SciFac meeting. We can also use the i-PRF because we know that we need to have a non-mobile biomaterials. The stability of the granules is essential in a bone graft. And the concept is to add the i-PRF to the bone graft, and then look what we have. We have a stack of a biomaterial. And then we can use it when we want to make a graft, because the stability of the granule is essential, but also we have a very nice protection of the granules, because now the granules are embedded into the new fibrin clot. Very easy to manage, very easy to obtain. We need only maximum 2 minutes to get this sticky bone. We cover with the A-PRF for sure, and after we can suture with my concept of apical mattress, with this new suture as a glycolon. This is a case in the mandibula. We want to make we know that the gingiva in the mandibula is very mobile, but now we can apply a graft who will be non-mobile. We do the augmentation. It's a mix of the i-PRF and the bone graft. The production of this eye bone needs only 1 to 2 minutes with the i-PRF. And then we cover with the A-PRF as usual, and the apical mattress as usual with the glycolon suture. I want to show you a case that we did today. It was a osteomyelitis in the tibia, and it was a dramatic case because this patient has had the infection since more than 6 months, and it was difficult to get healing. What we did, we started first to treat the site and to treat the infection by increasing the vascularization of the site. What we did several times PRF, and look how we changed the aspect of the site. A lot of vessels, and then we can go to the graft. We did a harvest in the iliac crest. This is the bone that the surgeon harvested, but we need to prepare a sticky bone. We used also collagen membrane. We put the collagen membrane into the box to hydrate it, and then look, we inject the i-PRF. Very simple. Few drops. And then after 1 or maximum 2 minutes, look what we can use. A sticky bone. And then we placed the bone graft into the site. This is the collagen membrane that we use for this technique. And then when you understand, dear colleagues, that if we respect the biology, if we are close to the biology, we will improve for sure our result. Very simply, very cheap, and we don't need to buy a lot of new products. We have in our body what we want. We just need to find how to get them. We have the platelets, we have the white cells, we have the growth factors, we have the BMP. Just we need only to find the right protocol to get them, and we have to apply the right protocol to respect what we have to do in the surgery. It will be my pleasure to host you in Paris next month for the SciFec meeting, and we will present all of these new techniques. We will have an immediate loading consensus conference. We will talk about hard tissue regeneration, soft tissue management, etc. It will be my pleasure to see you in Paris, or maybe in a future workshop or course in US. I would like to thank you for your attention and see you soon. Thank you.
If anybody has questions, they can enter them into the chat box to the right of the video. And meanwhile, I'll just repeat a few points from the beginning. There are 2 important links on the bottom of the video screen. One is for the form for the CE credits. Please fill in your details. And another is a link to our website where we have the PRF centrifuge system. And we also have information regarding vein light. Both are available on the Blue Sky Bio website for more information. Dr. Shukran, are you able to see the comments on the right side?
Yeah, I see the comments. Hello, Gary. How are you? Yes, we need only 1 to 2 minutes to go from the liquid phase to the solid phase for the i-PRF. Maximum is 2 minutes.
And what about there's another question on the top, i-PRF versus A-PRF?
Another comment is that we do the i-PRF and the A-PRF with the same machine. The i-PRF, we have to use a different tube. This is a new tube, and this new tube will be available only in 2 or 3 weeks because those tubes are in production. But we can use the same centrifuge, and if the dentist has already an old centrifuge from us, they can use the same centrifuge, but the protocol will be different.
The webinar should be available via the Blue Sky Bio website and also via YouTube for viewing at a later time. If there are questions, you could contact Blue Sky Bio or Dr. Shukran directly for more information. If There are no other questions at this time. I'd like to thank you very much, Dr. Shukran, for this presentation and for this webinar.
Thank you, Michael.
And I'd like to wish everybody a good evening.
Good evening. Bye-bye.